Ashley. Good to see you. And this is Dr. Ashley Mitek. And we're here at the College of Veterinary Medicine at the University of Illinois. And we are talking about multimodal sedation, analgesia, and, handling of the anxious or aggressive patient. And also about how there's a little bit of fear and a little bit of apprehension sometimes in our veterinarians and practitioners to really prescribe these combinations. So if you want to share with me some of the thoughts that you've had about that.
I think that there's some worries when practitioners are using multiple drugs in one patient, and they start to get anxious that, oh my gosh, I'm using many different types of drugs, and they may be a little bit uncomfortable doing that if they've previously been just using one drug for anxiolysis or one drug for pain management. But what we can say from the human literature, because it's something that's challenging to study in animals sometimes, but we know that multimodal analgesia and multimodal anxiolysis is quite beneficial. And the rationale for that is because if you use drugs that work on different receptors in the body, then you can potentially use a lower dose of each drug if you have multiple different drugs trying to get you to that same end game or what your goal is. So maybe if your goal is anxiolysis, you're using 2 different drugs or maybe 3 different drugs that work very differently in the body, and that way you can use lower doses of them. The same thing with pain management. Every day we use a multimodal analgesia approach for all of our patients, so that we can use lower doses of the opioids, lower doses of the alpha-2s, and minimize those effects, negative side effects we may see from those drugs by just being able to use lower doses of all of them. And so I think that the more that practitioners try out this multimodal approach, I think they'll find the more that they can get away with lower doses, and they may have potentially better outcomes for their patients.
Yeah, I think one thing that can be a bit challenging is, first of all, if I never have seen the worst side effect from a drug, I am scared, right?
Sure.
Is this the time I'm now going to see it? Or if I never, saw this combination, and like, how south can it go, right? How bad could it possibly be, and therefore how can I rescue them from that effect? So sometimes, like for example, my favorite thunderstorm cocktail, my storm sangria, is using propranolol. And then if this animal dog gets up to panic, meaning they're the ones who are jumping out of a second-story window, breaking their legs, had a case like that come in, or fracturing their canine teeth, trying to eat their way out of the crate, or digging until their toenails are bloody, they're in high panic, you need to add in something that's going to be sedating as well as anxiolytic. So diazepam, because it lasts 8 to 12 hours and is more sedating, Valium, with the propranolol and with the pheromone and going in the safe room and playing music, but that's the drug cocktail part, is adding that diazepam. I've had other practitioners question, doesn't their blood pressure really drop? How can you use propranolol? It makes the blood pressure drop. First thing I say is, remember, they're anxious. That anxiety is like triggering their norepinephrine and the heart rate to be up, and that's how propranolol is helping to prevent the racing off of the bloodstream, the heart rate. And actually, you're not going to see the low blood pressure for that reason, at least not in my clinical experience, but you're really not. Secondly, when you add on the diazepam, it still doesn't drop it because you're not at a high dose. You're only at 2 to 5 milligrams per dog. All right, I know that's a little bit of a range, but it's like just to effect, basically. To effect that they go, right? But still that thought of combining these two first time is very scary for them. So is there anything you can share about how can, when making these cocktail suggestions, this multimodal therapy suggestion, we can help we never want to eliminate, worry of side effects, yet how to balance that, how to balance your vigilance for a side effect or rationale for this patient, maybe I'll cut the dose a little bit more. No, we'll be fine with this dose for this guy,
I think that you are more experienced than I am with the behavioral modifying, using those drugs in behavioral modifying capacities. So I can't speak to that drug cocktail because I'm more of an intravenous girl. Like I need immediate results a second later under my anesthetized patient.
But you're so lucky they're all asleep.
I know, and they all have IV catheters. I love it. But I think that it brings up a good point that I know that even hopefully we all want to learn, and I want to continue to learn that even when I experiment with new drugs or new combinations of drugs, I certainly get a little bit more anxious because it's not something I've done before. And I think that brings up one point, which is that if you can reach out to somebody who has experience using those drugs, who has expertise in that field, then that is a great resource. And we should always feel that way in the veterinary medical community. I know that I don't know everything, but usually I can pick up the phone or I can text somebody or email and try and get some information on that. I think one of the drugs that maybe isn't used very commonly in outpatient at home treatment of anxiety or pain, but that we had chatted about was dexmedetomidine. And we certainly would advocate in appropriate patients for a combination of an alpha-2 and an opioid, and you could use that as multimodal anxiolysis, analgesia, a lot of great benefits to that. And we certainly get concerns from practitioners who haven't used alpha-2s very much, or they see that reflex bradycardia and get really, really, really worried about bradycardia with the use of alpha-2s. And that's something that in most situations, the patient's hypertensive, so they have this reflex bradycardia. And so we actually don't want people to give anticholinergics like atropine in those situations. Exactly. But it's really hard not to reach for the atropine bottle. I know that when you get a big dog that gets down to 35 or something like that, I think in all of us, we know that's not the normal. But just checking the blood pressure in that patient and continuing to monitor them. And I think that also rolls into the scenario you were talking about, which is that a lot of these drugs have dose-related side effects. Right. And so if you titrate that dose up, hopefully you'll catch it before it becomes a critical event.
Yeah, just go on, high, low.
Yeah, and you'll catch those patients hopefully before they get into not a great situation. But I think that with reason, we should all, I know everybody wants to provide the best care for their patients, and we're thankful that we do have more and more drugs coming out for anxiety relief, and being willing to experiment them with appropriate evidence and support and guidance. And I think continual monitoring, we should never be okay with the status quo.
Right. And I think also, too, it's nice to think that, well, my protocol for all, say, nervous dogs on a thunderstorm day before they're having surgery will be, trazodone at 5 milligrams per kilogram, and they'll all be fine. Well, no, he's not. This one got agitated. This one is not even touching. But to think more broadly about, like, okay, this is my patient coming in, and he's afraid of thunderstorms, and it's his day for the surgery, and we can't reschedule him. So how agitated does he get? And based on that, like how anxious and what is his body showing? And from that knowledge, we now have a better idea of which pre-med is going to help manage, not only manage those signs, but where they're working on the body. And then now knowing, oh, your pre-med was, say, trazodone and gabapentin together, because you got more anxiety reduction and more pain relief because you're going to go into surgery, and you also are getting a bit of that sedation. The two of those together a lot slower moving, so he's not digging at the cage and working his body up. And now you have those two on board. So then as you reach for maybe your alpha-2 and a narcotic, you may adjust the dose a little bit on there because of knowing what you already have for the pre-med and how those two work together,
And I think that there's a really interesting relationship which we continue to explore, but has been very well explored in human medicine, and we should assume to be true in our patients, this relationship of anxiety and pain.
Oh, absolutely, yeah.
And there are, if you read the textbooks, there are certain drugs that they say it has no analgesia, right? For example, drugs like benzodiazepines or propofol. And there's a lot of drugs that fall into that category that are strict anxiolytic drugs, dictionary definition of what we understand how they work at the receptor level. But what I don't think we appreciate or we address clinically enough in practice is the anxiety.
Absolutely right.
How significant it is to have an anxious dog. I guarantee you that a dog that is very anxious because maybe he's in a room and it's loud and the lights are on and people are coming and going and there's beeping and other dogs barking, versus maybe that same dog in a quiet room.
Absolutely.
With not a lot of commotion. I would strongly believe that they would have higher pain scores post-operatively and may have more adverse outcomes because we didn't address that anxiety pre-op.
Right.
And I think that's where it's really important. Again, my area where I've had some experiences doing anesthesia, and again, that's in an operating room, right, locked in an OR. And pretty much everything outside of that is not something we get involved in very much, but we do need to work on that as a team,
right,
with the owner, with the veterinarian, the referring vet, or whoever it is. How do we, if we know this dog is going to be anxious coming to the hospital, we know he's going to have surgery, well, there's enough drugs right now available that we could have the owner give at home. Exactly. So at least it takes the edge off a little bit when they walk in the door, and it just facilitates everything. It facilitates the anesthesia team placing a catheter, giving IM injections, and it keeps people safe.
Absolutely.
And I think a lot of, when we go back and look at bite reports or near misses, you go back and almost always you can say, could we have prevented this? Yes. And could it have been prevented, or could we have reduced the risk of this incident happening if we had decreased that patient's stress? And the answer is almost always yes.
Yes.
And to me, that really, I think that's I feel like we have somewhat become complacent in veterinary medicine. We expect the dogs to be stressed. We expect the cats to be stressed when they walk in the door. And certainly that's a normal physiological response. And we don't want our patients anesthetized when they walk in the door. But I do think that there's a middle ground, and I don't think we've fully researched, evaluated not just the pharmacologic options for anxiolysis in these patients, but the environmental.
Exactly. And
I think
where you do the exam, how you approach them, how you touch them, how do you modify and triage what you're going to do.
Pheromone. All of that.
Maybe behind the dumpster. I never thought I am being professional when I examine you out in the front lawn of my clinic for a dog who did not like to come inside.
Right.
But we could do it outside. Let's do it outside.
Then we need to have, again, I guess if I was going to summarize my thoughts on reducing anxiety and reducing pain in our patients, it would be a multimodal plan, use multiple drugs with lower doses, and then individualize that plan.
Exactly.
Everybody that I know that has done clinical work, everybody has their favorite cocktail, and that's totally fine. That you feel really confident that if I have that really aggressive dog, I feel good about this. But not every dog reads the textbook. Not every cat reads the textbook. Every practitioner would agree to that. And just expanding your toolkit, I think, is only going to help you provide better care to your patients.
And, there are ways, like at my practice, and I developed the Bella Behavior Medical Record System, which was a way that you could quickly determine where they were least stressful for exam, what was, whether you could use, say, food for motivator, and maybe favorite place or best place for blood draw, and quickly write it on the record so you got that individualized plan and everybody could follow it. And especially then if you did need to use medication, but based even on how are they responding, it helped you to clearly pick out which cocktail. And I would say 85% of the time I kept falling back on the same cocktail, for a pre-med. Yet I also kind of knew, like cooking, a little bit more of this and a little bit less of that, or one who was just goosey about the feet, like doing this dancing, that's a gabapentin dog. We're just going to use gabapentin. And they were much better for that because I understood how the drug worked and what the animal needed. So, well, thanks. I look forward to, expanding this whole discipline of reducing fear and stress and aggression. I'll say it, aggression during care in all aspects of veterinary medicine. And as I say, it's a gateway to care. This is the way that we can provide care, because if it's difficult on the animal, it's going to be difficult for the client, whether it's large or small, to be able to bring that animal to us, or for us even to get to them.
Right.
And then secondly, your assessment is more accurate. Your assessment is more accurate. You can palpate those muscles on a body that's more relaxed. And then secondly, if they're normally happy coming in here and here's the day they're acting very anxious, you immediately say, what's up? What's wrong? Because there is probably something medically, and even if it's environmentally that's changed at home, we need to know that too.
Yeah.
So we can help them. Well, thank you.
Thank you, Dr.
I appreciate this.
Great work.
Yeah. All right. Well, take care and keep it low stress.
We will.
Especially now you took your board exam.
Yes, I can.
So everybody's crossing fingers. Dr. Mitek is going to be, you are going to be board certified by the American College of Veterinary Anesthesiologist and what's the pain? Analgesia. And analgesia. Oh, that's a mouthful. Yeah. Okay. Well, thanks.
Thank you, Dr. Butt.
All right. Cool.